Okay, let us start off. So, a beautiful topic, atrial fibrillation, one of my favorites. So, a lot to learn in this. Alan Lindsay is the father of substance, teacher of substance and style, a great electrophysiologist. After Goldberger, you can consider him as the authority in ECG and other things. Earlier also we have seen during the. So these are the references, consulted many international references, and the entire presentation is based on today's international recommendations on this. This PowerPoint presentation, what happened? I will share with you. So you already know this conduction of cardiac impulse, and it starts somewhere in the SA node and through the atria into the AV node, and from there both the atria are activated. AV node bundle of phase, and the left bundle and the right bundle, anterior fascicle, posterior fascicle, all that we have discussed during our ECG classes. And this also, I don't have to go to that. Atrial fibrillation and flutter. Atrial fibrillation and atrial flutter are very fast electrical discharge patterns that make the atria contract very rapidly, with some of the electrical impulses reaching the ventricles and causing them, to contract faster and less efficiently than normal. Okay. So atrial fibrillation, the supraventricular, let's remove this term. Atrial fibrillation, it is a supraventricular tachyarrhythmia, most common arrhythmia seen in clinical practice. Atrial fibrillation is the commonest clinical arrhythmia seen in practice. 50% of population older than 70 years have atrial fibrillation. The prevalence of atrial fibrillation increases dramatically with age. So what is the most important factor? How old is the patient? AF is associated with 1.5 to 1.9 fold increased risk in death. It is characterized by disorganized electrical activity, progressive deterioration of atrial electromechanical function, with several theories of abnormal activation. ECG of atrial fibrillation, P waves classically are the atrial waves, they are absent. You have to look for the P waves and lead 2, lead 3, AVF and V1. This we already learned it. These are replaced by fibrillary waves or F waves. Low amplitude wavelets and mostly flat from the baseline, and these vary in amplitude and frequency and the shape. And AF is typically irregular ventricular response, irregularly irregular heart and pulse. If you have a clinic patient who has got an irregular heart and the pulse, you should consider atrial fibrillation. Usually the QRS is narrow, re-entrant pathways may be there. You can see in this ECG, the P waves are absent. Instead, the P waves are replaced by F waves, or the fibrillary waves are there. So P waves are absent. You can see here also there are no P waves seen, and we typically in V1, you can see that the F waves are there. Atrial fibrillation and flutter. Fibrillation, the QRS are regular. In case of atrial fibrillation, atrial flutter, QRS intervals are very irregular. This ECG part we have already seen. We are going to go into atrial fibrillation proper. What is WPW syndrome? What are the characteristic features? There is an accessory pathway called the Kent pathway. This bypasses the AV node. That is why PR interval is shortened. Because of shortened by PR interval, the P wave merges with the Q wave and produces a delta wave. And then the fusion QRS is the result of two activation sequences. One from the bypass tract, one from the regular AV nodal tract. STT changes are secondary to the changes in the ventricular activation. So what are the features? Shortened PR interval, delta wave, fusion QRS, and you also have STT changes associated. What is the importance of WPW syndrome? It can result in sudden cardiac death, ventricular fibrillation and sudden cardiac death. As you see here, this is the regular AV nodal pathway. There is a Kent pathway, the accessory pathway is there. This accessory pathway shortens the PR interval, and the PR interval is shortened, and this is the P wave, and after here is the PR. Now the PR is very shortened. There is a delta wave is there, and the QRS is widened, and associated T inversions. 4 abnormalities. 1, PR interval shortened. 2, appearance of delta wave. 3, there will be a wide QRS will be seen, and secondary T inversions will be there. This wide QRS is due to the double activation. Fusion QRS complex, that one. And the importance of that is it increases the risk of death and ventricular fibrillation. Pathophysiology of atrial fibrillation. What causes the atria to fibrillate? Initiating event and permissive atrial substrate. There must be a trigger, and the atrial substrate should be permitting the abnormal rhythm. Multiple mechanisms may be present. Focal pulmonary vein triggers enlarged right atrium and right ventricle. If a patient has got right atrial enlargement and left atrial enlargement around the pulmonary veins, the trigger starts. Multiple wavelets, mother waves, daughter wavelets, fixed or moving rotors and micro reentrant circuits, automatic foci in the atria. The precipitating factors may be catecholamine excess, hemodynamic stress, atrial ischemia, atrial inflammation, and metabolic stress. So these are the underlying conditions. Mortality and morbidity due to atrial fibrillation. The risk of thromboembolism is very great with atrial fibrillation. Disease-associated risk factors, loss of normal atrial contraction, so much so that there is stasis of blood, and stasis increases chances for thrombosis. Thrombus occurs in the atrial appendage, dislodges, and the clot enters into the systemic circuit or the brain circuit. If there is a right atrial appendage, the clot is there, it enters into the venous circuit. If there is a left atrial appendage, the atrial appendage is there only for the left atrium. The right atrial clot is there, it produces venous thrombosis. Left atrial clot produces systemic thromboembolism. Non-rheumatic heart disease, non-valvular cases, the stroke rate is 5 to 7%. If the rheumatic heart disease is there or valvular heart disease is there, the stroke rate 5 times it becomes more, maybe 25 to 35%. So fundamentally, I should know 2 things. What is the age of the patient? Is he having underlying structural heart disease? If there is a rheumatic heart disease or a valvular heart disease, the risk is much higher. If there is no RHD or valvular heart disease, comparatively the risk is lower. The reason for complications here are the stasis of blood, thrombus formation in the left or right atrium, dislodging of the thrombus into the venous or systemic circuit, and causing mortality. Mortality is doubled with underlying structural heart disease. So what are the symptoms of atrial fibrillation? AF present with a wide array of symptoms. Majority of the patients may only have an ECG abnormality. They may not be symptomatic. They may not come with palpitation, dizziness, or anything. Only routine examination of the ECG produces a diagnosis of atrial fibrillation. 3 days back, we evaluated one of my relatives in this hospital. He was totally asymptomatic, but the ECG showed atrial fibrillation. His age is 74 years, almost my age. Palpitations, dyspnea, fatigue, dizziness, and angina are the common presenting symptoms. Decompensate heart failure. Also, we have seen patients coming with polyuria. A patient with polyuria, sometimes, atrial fibrillation may be the underlying cause. Because of the polyuria, there will be increase in the BNP, bean natriuretic peptide, and that can produce the polyuria with increased bean natriuretic peptide produces polyuria underlying AF. In addition, AF can be associated with hemodynamic dysfunction and congestive cardiac failure, tachycardia-induced cardiomyopathy, and systemic thromboembolism. So, what are the symptoms now? Majority are asymptomatic. Palpitations, dyspnea, fatigue, dizziness, angina may be there. Decompensated heart failure may be there. Polyuria may be a presenting feature. Hemodynamic dysfunction and congestive heart failure, tachycardia-induced remodeling of the heart, which produces cardiomyopathy, and systemic thromboembolism is always a big threat in atrial fibrillation. What are the clinical signs of it? Irregular heartbeat. Pulse apex disparate. What is that? Pulse apex disparate? Pulse. How do you get the pulse different? One has to be auscultating, the other has to feel the pulse. Not the same person doing. So, okay. And start. Means all the heartbeats are not conducted. So, atrial fibrillation. Some of contractions are conducted to the pulse deficient or pulse apex disparate. May or may not have tachycardia, depending on the individual. Within the normal range. Variable intensity, this is another important. Exact may not be there, tachycardia may be there or may not be there. S3 is occasionally seen, S4 is usually absent. Okay. Absence of jugular wave, A waves in the jugular venous pulse. A wave again in the jugular venous pulse is because of the atrial activity. Because atria are not properly contracting, absence of A waves in the JPP, signs of underlying heart disease may be there, rheumatic heart disease, coronary heart disease, hypertrophic cardiomyopathy, dilated cardiomyopathy. Look for cardiac failure and atrial embolization. May have WPW associated ventricular rate usually more than 200 in case of WPW. Normally, narrow QRS tachycardia, sometimes may have wide QRS tachycardia. Again, summarizing the clinical signs. Irregular heart, pulse deficient, pulse apex disparity. Then tachycardia depends upon the AV nodal conduction. Okay, variable intensity of the first heart sound. Occasional S3, S4 is absent, jugular A waves are absent. Signs of underlying structural heart disease may be there. Look for cardiac failure and embolization. WPW may be associated. Normally, narrow QRS tachycardia, very rarely wide QRS tachycardia. It's very important for you, very striking. Less than 60 years, the occurrence of atrial fibrillation is 1%. The moment they come to around 60 to 79, it is 4%. More than 80 years, 8%. That means age is a very important variable as far as the atrial fibrillation is concerned. The older the patient, the greater are the chances for atrial fibrillation. So, what are the causes of atrial fibrillation? Underlying rheumatic valvular heart disease, diabetes, hypertension, CAD, LV dysfunction, male gender, advancing age, hyperthyroidism, congenital structural heart disease, left atrial and right atrial enlargement may be there, cardiomyopathy, alcohol abuse, illicit drugs, and acute pulmonary problems, cardiac surgery. This is a very standard question in your clinical viva voce. Because once you have a case of valvular heart disease, they will ask what will be the complication. You say atrial fibrillation, and then say what are all the causes of atrial fibrillation. You must just rattle out immediately. Rheumatic valvular heart disease, diabetes, hypertension, CAD, LV dysfunction, male gender, advancing age, hyperthyroidism. Among the endocrine diseases, hyperthyroidism is associated with atrial fibrillation. Congenital or structural heart disease, left atrial and atrial enlargement, cardiomyopathy, alcohol use, illicit drug abuse, acute pulmonary problems, and cardiac surgery. Okay. Now, causative factors. Hemodynamic stress, increase in the intra-atrial pressure, mitral and tricuspid valve disease, LV dysfunction, systemic or pulmonary hypertension. Atrial ischemia, CAD, ventricular ischemia, increase in the left atrial pressure. Sick sinus syndrome. Yes. What is sick sinus syndrome? It could be a short note. Sick sinus syndrome, the sinus node becomes fibrous. And it is the inherent focus of the impulse generation. Because it is fibrous, the rate of generation of impulse will be variable. And that produces sick sinus syndrome. Inflammation, drug use, alcohol. Endocrine causes, hyperthyroidism. Neurological causes, subacute sarcoid hemorrhage and stroke. Familial atrial fibrillation, there is one entity called the familial atrial fibrillation. It runs in families. Cardiac surgery and very rarely collagen disease. Okay. Atrial fibrillation with structural heart disease, rheumatic valvular heart disease, hypertensive heart, cardiomyopathy, congenital heart, coronary heart disease. Elevated BNP suggests underlying heart disease. One way of knowing that the patient is having underlying heart disease is look for the BNP. If the BNP, B-natriuretic peptide, is elevated, there is underlying heart disease. B-natriuretic peptide signifies atrial enlargement. AF without concomitant structural heart disease is called the lone atrial fibrillation. Once I gave this as a question for the MD students. Lone atrial fibrillation, short notes. Write short notes on lone atrial fibrillation. AF in younger patients without structural heart disease with low risk of thromboembolism. Hemodynamic instability, severe dyspnea, reduced oxygen saturation, fall of blood pressure, severe chest pain, and shock, etc. can occur. Okay. What investigations I should do? The easiest investigation, of course, is a 12-lead ECG with rhythm strip. Look for pre-excitation because of the WPW. Determine the heart rate. Evaluate the LVH and LBB. Look for previous myocardial infarction. QT-QRS intervals for patients with antiarrhythmic drugs. So what I should look in the ECG? Look for the pre-excitation syndrome. Look for the irregular heart. Determine the heart rate. Evaluate the LVH. Look for LBB. Look for the previous MI. QT and QRS intervals must be looked at in all patients with antiarrhythmic drugs. 6-minute walks test or exercise test. This is to see whether what is the rate like. Holter monitoring, electrophysiology not required regularly for atrial fibrillation, only in selected cases. Electrocardiography, echocardiography, transthoracic echocardiography, TTE, and transesophageal if you want to study the atria. Chest X-ray to evaluate the pulmonary disease, thyroid function, renal function, and electrolytes. Very simple investigations. 12-lead ECG and with a rhythm strip, 6-minute walk test, Holter electrophysiology rarely required, echocardiography to study the atria, X-ray for the pulmonary disease, TFT for thyroid, renal function, and the electrolytes. What are the differential diagnostic features? Atrial flutter, atrial tachycardia, atrioventricular nodal reentry tachycardia, paroxysmal supraventricular tachycardia, all these things we discussed in the ECG classes. WPW syndrome, digoxin toxicity, cardiac ischemia secondary to rapid ventricular rate, hyperthyroidism, and pulmonary disease. Now, how do I classify AF? First, you have diagnosed AF by seeing the various investigations like ECG and all that. Now, is it a chronic AF or a new onset AF? How do I know that? Looking at the previous ECGs. If the previous ECGs are normal and today's ECG only is showing atrial fibrillation, it is a new onset. Chronic atrial fibrillation, all his previous records also have. Today also he has got. Now, if it is new onset, is it paroxysmal? Is it persistent? Is it permanent? Classification of new onset AF is paroxysmal, last up to 7 days, usually 1 day, persistent, more than 7 days, permanent, that is, this is the cardioversion has failed. Okay. So, diagnosis of AF, chronic AF, new onset. In the new onset, paroxysmal, persistent, and permanent AF. Less than 7 days, more than 7 days, regular permanent AF with cardioversion failed. Now, paroxysmal AF, if it terminates spontaneously in fewer than 7 days, often less than 24 hours, it is called paroxysmal. Persistent AF, when it terminates either spontaneously after 7 days or following cardioversion. Permanent AF, it persists for more than 1 year, either because the cardioversion has failed or because cardioversion has not been attempted. Now, how does the AF behave? New onset may turn into permanent, and paroxysmal may turn into permanent, new onset to paroxysmal, new onset to persistent, paroxysmal to permanent, persistent to permanent. This is how the cycle goes. The first episode of atrial fibrillation, is it primary or secondary? A thorough evaluation is a must for atrial fibrillation. Structural heart disease and age are most important factors. Again, I am telling, when a patient of atrial fibrillation comes, what is the age of the patient? Is there underlying structural heart disease? These two decide the prognosis. Atrial fibrillation without structural heart disease is called lone atrial fibrillation. Thromboembolic risk is lower, prognosis is much better. Mitral valve disease, aortic valve disease, hypertension, coronary artery disease, left ventricular disease, dilated cardiomyopathy, hypertrophic cardiomyopathy, pulmonary embolism, atrial septal defect, increase in the thyroid function must be looked for. Tobacco, ethanol, coffee, stress, fatigue may trigger the AF. No organic heart disease, no WPW syndrome address the precipitating factors. Observe for recurrence of AF. If HD is underlying, that is heart disease is underlying, AC, rate control, rhythm control, or what is AC? AC is anticoagulation. Anticoagulation, rate control, rhythm control. Three important aspects. First one is the anticoagulation, AC. Second one is the reducing the rate. Rhythm control takes the last priority. Don't try to control the rhythm unless the patient is in failure, unless it is acute atrial fibrillation. Rhythm control takes a second priority. Anticoagulation and rate control are primary treatment goals. Paroxysmal atrial fibrillation. No underlying heart disease, rest, sedation, digitalis for the attack, hemodynamic compromise if occurs, immediate cardiac. That's what I said. Rhythm is important only when there is hemodynamic compromise. Hemodynamically stable, rate control, anticoagulation, and followed by rhythm control. What are the rate control drugs I have? Beta blockers, calcium channel blockers, flecainide, propafenone, IV may be used. Any one of these. Usually you go to beta blocker or calcium channel blocker. Flecainide and propafenone can also be used. No structural heart disease, prefer flecainide and propafenone. If there is structural heart disease, use CCB and beta blocker. Amiodarone is in patients with heart failure, dilated cardiomyopathy, and structural heart disease. Sotalol, a beta blocker in CAD and hypertension without LVH, because sotalol has got a positive effect on the CAD as well as hypertension. Catheter ablation and maze procedure in refractory cases. What is maze procedure? Any idea? Have you ever seen that? This is being done in this center. Maze procedure. What do you do in maze procedure? Pacemaker? No. Maze procedure is surgical procedure. Then you take the atrium, at each atria, dilated atria, and try to sort of electrically fibrous parts of the atria, tracts. So if you are making the atria fibrous, they will not be able to conduct the impulse. They will leave a channel through which only the electrical impulse goes. So they create a maze. What is maze? You would have seen children playing, up and down things going maze. Like that, they create a crisscross zigzag thing in the atria and leave one sort of pathway for the impulse to go. That is a very common curative procedure for maze. If patient is refractory, better to consider maze procedure. Chronic atrial fibrillation. Ventricular rate control, anticoagulants are very important. In acute atrial fibrillation with decompensation, we are interested in the cardioversion and then rhythm control. If it is chronic atrial fibrillation, anticoagulation and ventricular rate control. Cardioversion is needed only if hemodynamic benefit is expected. Either pharmacological rate control or DC conversion can be tried. Usually no more than one attempt of the DC. Reverting to sinus rhythm did not give an extra benefit. Many people think, no, the rhythm is abnormal. I wanted to bring it to sinus rhythm. That does not really have any great extra benefit through the FM trial. Long-term anticoagulation is a must. Risk-benefit titration is important. Catheter ablation to His bundle with pacemaker implant is the common procedure. Only if refractory, as it makes the patient pacemaker dependent. So you don't have to put pacemaker to every patient of atrial fibrillation. Atrial fibrillation, when hemodynamically not stable, when you also have other electrical coincidental problems, then you use the pacemaker and then the His bundle catheter ablation. Okay. What are my objectives of treatment? Relief of symptoms, prevent recurrence, and heart failure. Then prevention of systemic thromboembolism. It is in red, very important, very common arrhythmia. Thromboembolic complications must be prevented. Tachycardia-induced myocardial remodeling. So you can see practitioners treating atrial fibrillation. They may be trying to put some, manipulate the rhythm. Most important thing is thromboembolic prevention. You have to anticoagulate the patient. Tachycardia induced remodeling may be there. Management strategies: rate control, rhythm control, anticoagulation, warfarin 2 to 3, and cardioversion. So now you tell me, cardioversion, which is the patient suitable for cardioversion? A patient who has got acute atrial fibrillation, a patient who is elderly, and patient who has got thromboembolic risk is very high, and also a patient who is hemodynamically decompensated. Okay? In order to save his life. Suppose a patient came with hemodynamic stability, BP is good, circulation is all right, rate is not very high, and then the rhythm is irregular, of course. Then my priority is not rhythm control at all, not cardioversion at all. My priority is warfarin and rate control. For rate control, beta blocker, CCB, propafenone, and flecainide. These are the drugs that I use. Now, new onset atrial fibrillation, hemodynamically stable, no cardioversion, anticoagulate, and for 2 to 3 INR, keep the INR at 2 to 3 for more than 3 weeks. Not anticoagulated earlier, INR you keep it less than 2 for 3 weeks. Patient may come with a history that is already anticoagulated. Then you increase the INR to 2 to 3. If it is not anticoagulated, keep the INR to around 2 units. What is INR? How do you calculate?
Patient prothrombin time.
Patient prothrombin time and control prothrombin time. There will be two: control prothrombin time and patient's PT. Use these numbers, and you have to have a constant will be there for each prothrombin vial. There will be constant will be written. With that, you have to multiply that ratio. Patient prothrombin time divided by the control multiplied by that factor. That factor will be written on that vial. Okay, each vial will have that number. With that, you multiply and get the INR. Not a simple ratio. Okay, I will tell you about that in a different class. So suppose the patient is hemodynamically unstable, then you must consider cardioversion. Anticoagulated already, 2 to 3 INR is there for 3 weeks. Then you can try cardioversion, rate control, or OP form. Cardioversion, when I prefer, when the patient is elderly, when the patient has structural heart disease, when the patient has other complications. Rate control in moderate patients. And OP follow for other young patients. That's all. Now, not anticoagulated or INR is less than 2 for 3 weeks, warfarin and rate control. Trans-esophageal electrocardiogram, echocardiogram, look at the atria and the cardioversion also, and then the OP follow. Now, recurrent atrial fibrillation. Recurrent atrial fibrillation means patient has got atrial fibrillation, went home, and again he comes back. How are the symptoms? Minimal symptoms, disabling symptoms. Minimal symptoms, anticoagulation, rate control, no prevention, no antiarrhythmic drug treatment. Disabling symptoms, warfarin, rate control, antiarrhythmic drug treatment, and prevention of the arrhythmia, depending on the symptoms. Recurrent atrial fibrillation, now we have looked at a new onset followed by recurrent atrial fibrillation. Minimal symptoms, anticoagulation, rate control, no antiarrhythmic drug. Disabling symptoms, anticoagulation, rate control, and also rhythm control using a EAAD. Okay. Most important conundrum or dilemma is, should I control the rate? Should I control the rhythm? As I told you, always give preference for the rate control and not the rhythm control. So you have to integrate several factors: age of the patient, degree of symptoms, likelihood of success of cardioversion, status of anticoagulation, presence of atrial thrombus, presence of comorbidities. One important point here: if you do an echocardiogram and find a clot in the left atrium, you should not attempt to do the CV. Why? If I do cardioversion, it will restore the normal rhythm. Normal rhythm means powerful atrial contraction will come. The clot will be propelled. So, whenever there is a clot, you must give at least 3 weeks of anticoagulation. Then only look for the cardioversion. If there is no clot in the atrium, then you are justified in going for the cardioversion. Now, there are 2 big trials, FM trial and RACE trial, rate, rhythm, and anticoagulation. Which is important? Younger patient, rhythm. Comorbidity, older patient, rate. Anticoagulation, must fulfill. Now, what do you decide? You want to go for rate control or rhythm control? Younger patients without comorbidity, first time atrial fibrillation, new onset atrial fibrillation, no structural heart disease, prefer for the rate control, not the rhythm control. Comorbidity is there, and then you only go for the rate control. Anticoagulation is a must for both the patients. Anticoagulation. Atrial fibrillation is a powerful risk factor for stroke. Most important treatment in atrial fibrillation is anticoagulation. Acute cardioversion is risky without anticoagulation. That means you should have given at least 2 to 3 weeks of anticoagulation. Then only do the cardioversion. Very important point. Risk is same for electrical and pharmacological cardioversion. Cardioversion can be electrical cardioversion using a defibrillator or using antiarrhythmic drugs for a pharmacological cardioversion. TE increases the risk if AF is more than 48 hours. If the thromboembolic risk, TE is thromboembolic. Thromboembolic risk increases if the atrial fibrillation lasts for more than 48 hours. Effective anticoagulation reduces the risk by threefold. Initiation of anticoagulation can be done either with a low molecular weight heparin or a conventional heparin. Once the initiation is done, you can convert them onto warfarin because very least expensive medicine and very easily affordable by all patients. But we have today several modern drugs like, direct thrombin inhibitors or factor inhibitors are there. These, there is no INR is required for them. They are expensive, but monitoring is much easier. If you use warfarin, you require regular monitoring of the INR. So depending on the patient's economic condition, either I use warfarin for continuation or I give a costlier medicine like, the direct thrombin inhibitors or the 10A inhibitors, where there is no INR measurement is not required. Okay, so anticoagulation is a must. Cardioversion should not be attempted without anticoagulation. Cardioversion, electrical or pharmacological, can be tried. If the atrial fibrillation more than 48 hours, we are thromboembolic risk increases. Anticoagulation reduces the risk of thromboembolism by threefold. Initiate the anticoagulation with heparin or low molecular weight. Continuation will be warfarin for poor patients. Affordable patient, you can put them on Gemilatron or any of the direct thrombin inhibitors or your Pixiban, which is the 10A inhibitor. One of those things you can give. So what are the risk factors for stroke in atrial fibrillation? Male gender, advancing age, rheumatic valvular disease, diabetes, hypertension, CAD, LV dysfunction, heart failure, prior history of TIA. So all these things I have to put, and there is a summary score which is called the CHAD score, which I will show you. Male gender, what happened? Male gender, advancing age, rheumatic valvular disease, diabetes, hypertension, CAD, LV dysfunction, heart failure, prior history of TIR. This every patient should get the CHAD S2 score. What is CHAD S2 score? When you are getting atrial fibrillation, 1 point cardiac failure, 1 point for hypertension, 1 point for age more than 75. C for cardiac failure, hypertension, A age, and D for diabetes, and S2 for stroke. Why 2? 2 is because I am giving 2 points there. C 1 point, H 1 point, A 1 point, D 1 point. Cardiac failure, hypertension, age more than 75, diabetes. When you have got thromboembolism or TIA, you give 2 points. Now you have got the summary. Maximum there could be 6 points. Out of that, how many he has got? 0. That means age-adjusted stroke incidence is only 1.9. 1 means 2.8. 2, CHAD score 4. CHAD score 3, 5.9. CHAD score 6, 18.2% a stroke in 1 year. So very important. Non-valvular atrial fibrillation treatment with anticoagulation is based on the stroke incidence. Risk factor stratification. The moment you diagnose it, you have to stratify the patient. High risk, moderate risk, and other risk. High risk factors, rare stroke, rare TIE, and thromboembolic event. Moderate risk, age more than 75, hypertension, heart failure, EF is reduced, diabetes. Other risk factors, female gender, CAD, hyperthyroidism, age less than 75, or lower category of risk. So what I have to do? CHAD score I have to do and risk stratification I have. Now, treatment. What sort of drug treatment I give? Age less than 65, no risk factors, no anticoagulation, only 325 aspirin. This is the thrombus preventing mechanism. 60 to 75, diabetes is there, CAD is there, one risk factor, give aspirin. Two risk factors, 2 to 3 INR you have to keep warfarin. Age more than 75, multiple other risk factors. Warfarin, keep the INR at 2.5 to 3.5. This is the atrial fibrillation with anticoagulation. Previous slide is non-valvular atrial fibrillation with anticoagulation. This is about those people who have valvular disease with anticoagulation. Now, risk of thromboembolism, less than 60 years, 1.5%. More than 80 years, 23%. That means the age is a very important predictor for thromboembolism. How do I prevent? Atrial fibrillation is associated with increased risk of thromboembolism, stroke, TIA, peripheral embolism. Anticoagulation with heparin and warfarin to reduce TE. Anticoagulation, risk of fatal bleeding may be there. Monitor the INR. Antiplatelet treatment with aspirin, clopidogrel also for milder cases. Use CHAD-2 score to stratify the patients. CHAD-2 score 0, need only aspirin and clopidogrel. CHAD score of 3 or above, need warfarin and heparin. Score of 1 and 2, see history of stroke and the gender and then decide. So what are the anticoagulants I have? Heparin, low molecular heparin, warfarin, nicomonolone, phenidiones, and zimilgatran. Either zimilgatran or apixaban. So, trade name Biparin, Fluxam, Univarfin, Actrom, Dindivan, these are the various trade names. And dabigatran is the direct thrombin inhibitor, direct thrombin antagonist. XA inhibitor is the apixaban, available as Eliquis. Probably you may be prescribing Eliquis, some tablet like Eliquis 5 milligrams. Okay, so these newer drugs are very good. No monitoring is required, but only thing is they are expensive. How to assess the bleeding risk? Very important, History of previous bleed, 2 points. Hepatic or renal disease, 1 point. Alcohol intake more, 1 point. Malignancy, 1 point. More than 75, 1 point. Aspirin therapy, 1 point. In spite of aspirin, if he is having bleeding, means 1 point. Reduce platelet count or platelet function, 1 point. Hypertension, 1 point. Anemia, 1 point. Genetic predisposition, 1 point. Excessive fall risk, 1 point. Patient of stroke, 1 point. As you can see, everything has got 1 point except history of bleeding, which is 2. There are total 5 plus the 4, 3, 6, and here another 6. 12 are there. 13 can be the maximum score. So 0 points, that is the risk. 5 or more points, 12 points. So bleeding risk increases as the number of points increase. Bleeding risk outweighs the benefit, no anticoagulation. Pregnancy, especially first trimester, no anticoagulation. Whenever you are planning elective surgery also, anticoagulation can be temporarily stopped. Rate control. Control of the ventricular rate is critical component. Rate controlling agents act by increasing the AV nodal refractoriness. Beta blockers and CCBs are first line treatment. Give either IV or orally depending on the emergency. RVID patients, we need to exert caution with the beta blockers because it precipitates the RVID and asthma. Heart rate less than 88 rest or less than 110 with exertion. 6-minute walk test and TMT are good guides for the rate control. Digoxin is rarely used as monotherapy, somewhat useful in patients with heart failure. Amiodarone, class 2 recommendation for rate control. So what are the drugs I have? Beta blocker, calcium channel blocker, oral or IV. If the heart rate is less than 88 rest and less than 110 with a 6-minute walk exertion, you don't have to do any rate control. Main drugs for rate control: beta blockers, calcium channel blockers, diltiazem, verapamil. Digoxin very rarely. Commonly used beta blocker, beware of the asthmatic patients. CCBs, diltiazem, verapamil can be safely used. Digoxin, you keep it away a bit. So rapid rate control, IV drug should be used. IV CCB, diltiazem, verapamil, beta blocker, metoprolol, esmolol. Diltiazem is preferred because of the least side effects. For patients with increased sympathetic tone, in order to reduce the sympathetic drive, you can use esmolol, which is a beta blocker. It not only controls the rate, it also reduces the sympathetic tone. AF with heart failure, digoxin is the choice, not CCB or beta blocker. Digoxin has delayed onset of action, not immediately effective. Amiodarone is the choice in AF with heart failure and hypotension. Flecainide and amiodarone in atrial fibrillation with pre-excitation. CCB digoxin are contraindicated in WPWC. Now, rhythm control. Rate and rhythm control yield similar results. Young patients who remain symptomatic after rate control, you can try the rhythm control. In whom rate control drugs are contraindicated, try rhythm control. We do not tolerate rate control drugs, then you can use rhythm control. Rate and rhythm control drug combination, not CAB used, can be used. So, 1C class, flecainide, propafenone are contraindicated if there is a coronary artery disease. In CAD and diastolic heart failure, amiodarone is the drug of choice for rhythm control. Sinus rhythm requires treatment with CV risk factors and hyperthyroidism. Antiarrhythmic drugs restore the sinus rhythm. Amiodarone is safe and effective to restore sinus rhythm. Its adverse effects may be a problem. Sotalol is effective maintenance for sinus rhythm, requires monitoring of the QT interval and electrolytes. It is contraindicated in patients with structural heart disease. Catheter ablation is an alternative to drug therapy in symptomatic patients without structural heart disease. Okay. Now, what are the various anti-arrhythmic drugs I can use? Amiodarone, dofetilide, sotalol, flecainide, propafenone, and dronedarone. What class of drug is that? What is the dose? What is the indication? And what are the side effects and special precautions? This is very important, this one. Maintenance of sinus rhythm. No significant structural heart disease. Flecainide or propafenone, sotalol. If necessary, amiodarone, dofetilide, and then the catheter ablation. Suppose patient has hypertension. Is there LVH or no LVH? If there is no LVH, flecainide, propafenone, sotalol followed by amiodarone. And cardiac catheter ablation final. And if there is hypertension with LVH, left ventricle thicker than 20 millimeters, then amiodarone and cardiac ablation. Coronary artery disease, dofetilide and sotalol, amiodarone, cardiac ablation. Heart failure, amiodarone, dofetilide, cardiac ablation. Likewise, depending on whether you have structural heart disease, hypertension with LVH, without LVH, CAD, or heart failure, we have to choose the drug. Okay. Cardioversion. Effective cardioversion and emergency cardioversion. Elective and emergency. Electrical and chemical, both can be done. Ebutilide 4, class 3 drug, most successful when initiated within 7 days. Acute cardioversion in hemodynamically unstable patients, pharmacological cardioversion, no sedation or anesthesia is required. But risk of left ventricular arrhythmias, serious arrhythmias can occur, ventricular tachycardia. Direct current DC energy cardioverter is used. Maintain serum potassium, the upper normal range before cardioversion. Hemodynamically unstable patients with AF, severe dyspnea or chest pain with AF, patients with pre-excitation in ECG, WPW, non-responders of AF with rate control therapy, patients without any valvular functional heart abnormality, DC cardioversion, electrical current that is synchronized to the QRS complex, monophagic or biphagic waves. What is the energy I use? 100 to 200 joules. The success in short duration atrial fibrillation, it is very successful. In whom left atrium is not significantly large, cardioversion is successful. The success rate of cardioversion exceeds 70%. Patient is sedated or anesthetized during the CV. Embolization is the most important complication, so thrombus in the atria must be ruled out before you do a cardioversion by doing a transesophageal echocardiogram. Or warfarin must be given 4 weeks before the cardioversion. Patient must receive warfarin for at least 4 weeks. After that, only cardioversion. Complications of cardioversion: thromboembolism, pulmonary edema, hypotension, myocardial dysfunction, skin burns, STT changes, elevated cardiac markers, synchronization of DC shock with QRS prevents serious ventricular. If you can synchronize the shock with the QRS, serious ventricular arrhythmias can be prevented. Pharmacological cardioversion. Electrical cardioversion is the most commonly used. Pharmacological cardioversion, if direct current cardioversion fails, or in some cases are a pre-cardioversion strategy. Pre-treatment with amiodarone, plecanide, ibutylide, propafenone, sotalol increases the success of DC cardioversion. This is not a choice in hemodynamically unstable patients, where the choice is only DC cardioversion. Who should be admitted? Suppose atrial fibrillation patient comes. Whom I should admit? Whom I can send in the OP? Hemodynamically unstable patients, those who have new onset atrial fibrillation, associated underlying structural heart disease, who are in heart failure, patients older than 65, suspected of acute coronary syndrome, or other comorbid medical problems. Long-term management: reducing the chances of atrial fibrillation recurrence, reducing the atrial fibrillation-related symptoms, control of ventricular rate, reducing the risk of thromboembolism, management of CV risk factors. Anticoagulation is a must for all except the low atrial fibrillation, younger patients, rhythm control, older patients, rate control. AF begets AF, sinus rhythm begets sinus. If patient is having AF, further AF is possible. The moment he gets into sinus rhythm, chances of staying in sinus rhythm. What are the surgical treatments? Atria are transected and resutured to the critical mass. They reduce the size of the atria. That is one surgery. Surgical maze procedure is an attractive procedure. Catheter ablation, widely used. Compartmentalization with continuous ablation lines, catheter ablation, focal triggers of atrial fibrillation, AV node ablation, insertion of permanent pacemaker. Another option. Percutaneous closure of the left atrial appendage to reduce the thromboembolism. Post-ablation antiarrhythmic therapy should be continued. What are the take-home points? Atrial fibrillation is the most common arrhythmia. Evaluate any underlying structural heart disease. Classify the patient and risk stratify using the CHART score and also the bleeding risk. Thromboembolism is the main threat. Age is very strong risk factor. Anticoagulation warfarin is the mainstay of treatment. Rate control with beta blocker CCB must in all. Antiarrhythmic rhythm control only in selected cases. Cardioversion, catheter ablation, may in selected patients. That's all. End of the story. Now, a few recap points. Because once the presentation is over, then we can say, so it's a very common arrhythmia, isn't it? Atrial fibrillation, right? So when you have atrial fibrillation and the patient comes, what are the minimum things you will say? What is the age of the patient? Less than 65, more than 65. Less than 65, prognosis is good. More than 65, prognosis is relatively bad. Second, is there underlying structural heart disease? Like rheumatic heart disease, coronary heart disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, alcoholic cardiomyopathy, diabetes underlying, or previous history of thromboembolic episodes, previous history of bleeding, these also risk will be higher. Okay. How do I diagnose atrial fibrillation? The Lully ECG with the rhythm strip. You may not require the Holter monitor and all very much. And also, what else I should look for? Look for structural heart disease. Look for comorbid conditions. Evaluate thyroid. Evaluate for diabetes. Because thyroid could be an underlying cause for it. So, what is the common cause of atrial fibrillation? Depends on the age. Younger patients, rheumatic heart disease, left atrial enlargement, mitral stenosis. Elderly patient, no structural heart disease, ischemic atrial. Young woman, hyperthyroidism, atrial. So you have to keep an eye on all these things. Always do a chart score and always look for the thromboembolic risk. Okay. What is the mainstay of treatment of atrial fibrillation? Anticoagulation is the treatment. Okay. Rate control and rhythm control. When do you choose rate control? When do you choose rhythm control? When the patient is having no structural heart disease, presented with a chronic atrial fibrillation, our aim is to control the rate and not the rate. Unlike another patient who has got structural heart disease, hemodynamically unstable, and then he is presented with new onset atrial fibrillation, rhythm control will be a priority. Generally, rate control. Sometimes rhythm control. What are the methods of rate control? Beta blocker, calcium channel blocker, Ticanate, propofol. If there is underlying CHD, MDR, we can use. Generally, antiarrhythmic drugs are not generally used for rate control, only for the rhythm control. Okay. Supposing I want to control the rhythm, how do I do that? Best is DC. DC is the best. Okay. If not able to do the DC or it is space, then you have to go for the drugs. What drug you use depends upon what is the structural heart disease, LVH is there or not, hypertension, CAD, and then the arrhythmia is there, depending on that. One other important thing I should always look for is the associated WPW. WPW increases the risk of cardiac failure and sudden cardiac death. So you must always look for pre-excitation. Catheter ablation and pre-excitation control is also used. And the risk of thromboembolic complications always increases with the age and underlying structural heart disease. Okay. If I want to do cardioversion, one important thing is look at the atria and clot. If there is already a clot in the atrium, you should not do the cardioversion. Because by doing cardioversion, you would make the atria contract. Then all the clot will go nicely. I have allowed the clot. Then how do I handle? Give them warfarin for 4 weeks, maintain anticoagulation 2 to 3 INR, then do the cardio. What are the drugs for anticoagulation available? Immediately heparin, low molecular heparin. And then to take over, we have to use oral anticoagulation. Why can't I start straight away warfarin and not low molecular weight?
1 week for message from.
It takes 1 week for the oral anticoagulation to build up. During that 1 week, you may have thromboembolic complication. So immediately I must put him on conventional heparin or low molecular heparin. And after a week, the oral anticoagulation time is simultaneously started. Then you withdraw the heparin and warfarin will continue. Warfarin is the choice in all patients because it's a very cheaper drug. And the problem with warfarin is we have to monitor the INR, PT-INR we have to monitor always. And also you have to avoid foods which contain vitamin K. Because this is vitamin K blocker. If you use warfarin, which is a vitamin K blocker, and also supplement vitamin K orally with all the cabbage and all that stuff, green leafy vegetables, warfarin dose you have to increase. Can't keep the INR. Always patient will ask, What food I should not take? Yeah, you are on warfarin. So don't take green leafy vegetables, spinach, cabbage. These are all containing vitamin K. Okay. Now warfarin story is over. Now new drugs have come. Dabigatran is there. Zibilgatran is there. These are all direct thrombin inhibitors. Direct thrombin is 2A. Factor 2 activated becomes activated thrombin is called 2A, and that is the final step. The final step of coagulation is activation of thrombin to thrombin to produce thromboplastin and go further. This one finally the fibrin forms. Before the fibrin formation, the final step is the thrombin activation. It blocks that 2A. That is the dabigatran or gibilgatran, any one of these things. Or you can use XA, that is 10A inhibitor, which is apixaban, like your Eliquis or something. These are expensive, but you don't have to monitor the PTI. Always titrate the bleeding risk. Look for bleeding risk. There are points for each one. Risk benefit ratio should be seen. Pregnancy, first trimester, no antibiotic. Okay, so this is the story of atrial fibrillation. These are the important catch points, whatever I have summarized. Don't know whether anything else is. So very most common arrhythmia evaluate underlying SCD classification stratification we have seen. Surgical treatments. Surgical treatments are AV, atrial transection, maze procedure, catheter ablation, and then permanent pacemaker. Yeah, when I should admit also, you should know. You should be admitted. Everything is there in this presentation. What I will do is I'll share this presentation as well as this video. You can use that. Okay. We'll stop here.